Can you hear me?
Yes, ma'am.
Yes, ma'am.
Good morning. Shall we start?
Good morning, ma'am.
How many of you have joined for this class? Or can I get the attendance? Can somebody send me that attendance after the class?
Ma'am, attendance, ma'am, chat box, roll number wise message. Hello.
Hello. Tell me.
Ma'am, attendance would be chat box, roll number by the end of the
118 batch. How many students are? I don't know.
Ma'am, 175.
175. Total 175?
Yes, ma'am. Zoom la 100 will be joining
YouTube. Okay. First time I am, I don't know. When will you meet in person? I don't know. Anyway, we will start. First, my first class for you. Okay. Shall we start?
Yes, ma'am.
Yes, ma'am.
I think you people are more familiar with the embryology than me, right? Because you are fresh from embryology. Third some students. Okay. Tell me. Yes or no? Huh? Yes or no?
Yes, ma'am.
Yes, ma'am.
Okay. Okay. Anyway, I will teach you something about the development of the placenta and the disease arising from the placenta. Trophoblast. Okay. So, as you know, after fertilization, the segmentation of the ovum begins. At which stage this fertilized ovum reaches the uterine cavity? It is in the morula stage. That is a 16 cell stage. That you all know. Yes. Huh?
Yes, ma'am.
Okay. And that morula is still surrounded by the zona pellucida. Can you remember that things in your from your embryology classes? Yes.
Yes, ma'am.
Okay. Okay. After some time, this zona pellucida disappears. This zona pellucida doesn't have the property to invade into the uterine cavity. Okay. But after some time, this zona pellucida disappears. And the cells lining the surface of the morula is called the trophoblast. this trophoblast has the property to attaching itself and invading in the tissue that it comes in contact with. Got it? So the trophoblast is the thing that causes the sticking of the morula into the uterine cavity. Can you imagine that? Somebody's.
Yes, ma'am.
Okay. What happened? My slot was started. So after the disappearance of the zona pellucida, the cells of the trophoblast stick into the endometrium. That is called the implantation. You imagine the uterine cavity and the morula in the uterine cavity after the disappearance of the zona pellucida that is stick into the endometrial cavity. That is the uterine cavity to the endometrium that is stick. And there after the disappearance of the zona pellucida, this implantation starts. That is the outer layer of the morula called trophoblast has the property for sticking and invades into the cells that which it comes into contact with. That's why after the disappearance, zona pellucida doesn't have the property to invade, but the trophoblast has the property to invade. Trophoblast is the outermost layer of the morula. Okay, trophoblast invade the endometrium. So that invading of the morula into the endometrium is called the implantation. So after that, the trophoblast invade the endometrium and goes deeper and deeper into the uterine mucosa till the whole of it comes lying within the thickness of the endometrium. So after implantation, the whole of the trophoblast, that is the trophoblast invades the endometrium and the whole of the morula get into the layer of the endometrium. So you can see it. The morula is inside the endometrium. That is called the implantation. That is the it's an eccentric implantation in the human beings. You can see this from you can see the morula that is can you see? You can refer your embryology text and you will get this figure there. You can see the uterine epithelium trophoblast and that is entering into the uterine cavity into the endometrium, and finally it goes to the into the substance of the decidua. Okay, means endometrium. Okay, got it?
Yes, ma'am.
Yes, ma'am.
So that is implantation. When the trophoblast, that is the morula stage of the fertilized ovum, get embedded into the endometrium within the portion of the endometrium, that is the implantation. After implantation, after the implantation of the embryo, that is called the endometrium is called the decidua. You should study all these things because these terms are very important while you are studying the obstetrics, fertilization, implantation, delivery, and stages of the everything. These I mean this decidua, decidalization, decidua. These type of words, they are all very important in your practice. That is in our department. That is in the obstetric department or obstetrics in your obstetrics. Then after implantation, the uterine endometrium remain the secretory phase. That is, all of you know that the implantation occurs after in the secretory phase, and the endometrium remain in the secretory phase, but maintain and that become intensified. Intensified means the cells, the stromal cells become enlarged, become vacuolated, and store glycogen and lipids. That is for the further development of the embryo. Okay, then this change of stromal cells is called the decidual reaction. All these terms are very important. Then the portion of the decidua where I am not familiar with this laptop. That is why there is some problem. Please pardon me. Okay. Portion of the decidua where placenta is formed is decidua basalis. You can see that in your figure. That is the placenta that is. Hello. Portion of the decidua where the placenta is formed is decidua basalis. That is the base part of the implantation. Then the part of the decidua which separated from the lumen, that is called the decidua capsularis. And the rest of the decidua, that is the rest of the endometrium, is called the decidua parietalis. And you can see this, where the embryo is embedded, that is in relation with the decidua, that is called the decidua basalis. And the portion of the decidua that separate the uterine cavity, that is decidua capsularis. The rest is the decidua parietalis. Coming to the villi, that is the formation of the villi. That is the essential functional elements of the placenta is very small finger-like process or villi. I think you have studied all these things. This is just a revision for your embryology class. Okay, because this is a, have you, anybody has seen placenta in your life? Anybody? Placenta, delivery? Why did yes or no?
No.
No. So when you come to a labor room, you are very familiar with all these things, but these things are very important. The development of the placenta. The placenta is from our department. In our department, it's very important, so that you should study all these things. And the development of the placenta, you should know how the placenta develops. But that after the delivery, how the placenta is delivered, whether it is completely delivered, what are the types of the placenta, all these are very important in our department. So that's why we are, you should know all these things. Development of placenta, you should know generally. But the functional elements, everything you should study. That is the importance of placenta. So the essential functional elements of the placenta are very small finger-like process or villi. These villi are surrounded by metal. This is in general I am talking. We will later we will come to the how it develops. That is villi is formed. These villi are surrounded by maternal blood, and the substance of the in the substance of the villi there is capillaries through which the fetal blood circulate. That through these villi the fetal blood and the maternal blood circulate. That we will study in your physiology of fetal circulation. But here we are discussing only about the development of the placenta and the trophoblastic disease. Exchange between the maternal and the fetal circulation take place through the tissues forming the walls of the villi. Okay, this is a figure that you will study later. Or you can refer to the, I don't know how to explain to you through this picture. That from after the formation of the villi, I will tell you. The villi are formed as offshoots from the surface of the trophoblast. That is, already the trophoblast is embedded into the endometrium. That is the decidua. And as the trophoblast along with the underlying extra-embryonic mesoderm constitute the chorion. So the trophoblast along with the underlying extra-embryonic mesoderm is called the chorion. The villi developed from here it is called the chorionic villi. That is why this name came as chorionic villi, since it is developing from the chorion. Okay, the chorionic villi are first formed all around the trophoblast. That is, it's a round structure. So villi is formed all around and grow into the surrounding decidua. Those related to the decidua capsularis are transitory, and after some time it degenerates. Okay, this part of the chorion becomes smooth, and this is called the chorion leaf. Then, so at first these villi are developed all around the trophoblast, but later the villi that is in relation to the decidua capsularis is become degenerate and become chorion leaf. In contrast, the villi that grows into the decidua basalis, that is where the embryo is attached, undergo considerable development. Along with the tissues of the decidua basalis, these villi form a disc-shaped mass which is called the placenta. That's why that is how the placenta is formed. We will come to we will come to it later in detail. The part of the chorion that helps to form the placenta is called the chorion frondosum. So the other one is the chorion that helps to form the placenta, that is chorion frondosum. Whether it degenerates, that is called the chorion leaf. Okay. So here you can see all around the villi can be seen. And the second picture, that only the chorion, the where the decidua basal is, there is the villi is persisting. Okay. So the trophoblast is first made up of a single layer of cells. So that is the outer layer of the embryo. That is the trophoblast or the morula stage. As these cells multiply, two distinct layers is formed, and the cells nearest to a decidua lose their cell boundaries. Thus, one continuous sheet of cytoplasm contain many nuclei is formed. Such a tissue is called the syncytium. Hence, this layer of trophoblast is called the syncytial trophoblast. So, first there is only a single layer of trophoblast. Later on, that multiplies. That part of the trophoblast which is in contact with the nearest to a decidua lose their cell boundaries. A continuous sheet of cytoplasm containing nuclei is formed, and the trophoblast, hence this layer of the trophoblast is called the syncytial trophoblast. That tissue without cell boundaries having only the cytoplasm and the nuclei. That is called the syncytium, and this layer of trophoblast is called the syncytial trophoblast. Can you imagine? First, there is a single layer of cells, then it multiplies, and the multiplying cells that is close to a decidua lose their cell boundaries, and a sheet of continuous cytoplasm with a nuclei is formed. That is called the syncytial trophoblast. You can see. I don't know whether you can see it clearly. After that, deep to syncytium, the cells of the trophoblast retain their cell walls. That is, a single layer of cells retain their cell wall. That is called the second layer, and form the second layer. And the first layer that is close to the decidua become multiplied, and they lose their cell boundaries, become a sheet of cytoplasm and nuclei, and that is called the syncytial trophoblast. And the second layer is cytotrophoblast. That is deep to syncytium. The cells of the trophoblast retain their cell walls. That is, it is having the shape of the cells. So, and it's a single layer of cell that is called the cytotrophoblast. So, the layer of the trophoblast that is close to decidua is syncytial trophoblast, and the other one is the cytotrophoblast. The syncytial trophoblast grows rapidly and become thick. Small cavities. At that time, the cytotrophoblast is having only one layer. But the syncytial trophoblast first grows rapidly and become thick. Small cavities called the lacunae appear in this layer. Can you imagine? You can see that cavities here. Lacunae in the syncytial. The dark part is the syncytial trophoblast, and the cell single layer cell is the cytotrophoblast. You can see lacunae in that. First, the syncytial gradually the lacunae increasing size, and at first this lacunae, as I shown in that picture, it is irregularly arranged, but later on this comes to lie radially around the blastocyst. Okay, the lacunae are separated from one another by the partitions of the syncytium. Can you imagine? Radially some lacunae are arranged, and in between them there is that is lacunae are separated by another partitions of the syncytium. That is called the trabeculae. So trabeculae, in between the radially arranged lacunae, there is trabeculae. The lacunae gradually communicate with each other. That is, at first they are cavities, then these cavities come to lie around the what is that called? Syncytium. Okay, that space is large space, and eventually one large space is formed. That is called the lacunar space. The syncytial trophoblast then now grows into the endometrium. Then as the endometrium is eroded, some of the blood vessels are opened up. That blood from them fills the lacunar space. That is, the maternal blood comes in contact with the lacunar space. So first lacunae is formed, then they are arranged radially, then they communicate each other and separate the trabecula by the lacunar space. Then the lacunar space, the syncytial trophoblast goes into the endometrium. Some of the blood vessels come in contact with the lacunar space. That is the maternal blood that is comes in contact with the lacunar space. Okay. Each trabeculus is initially made up of entirely of the syncytial trophoblast. Right? So that now the cytotrophoblast begin to multiply. Previously, first only the syncytial trophoblast multiply. But later on, after the lacunar space is formed and when they come around the syncytium and when the syncytium grows into the endometrium and the maternal blood comes in contact with the around the syncytium by the in the lacunar space. Now the cytotrophoblast begins to multiply. Previously it was a single layer of cells. Now it starts going to the trabeculus. That is, the trabeculus now comes to have a central core of cytotrophoblast covered by an outer layer of syncytium. Okay. So can you imagine that? First, a single layer of cytotrophoblast and multiple layer of syncytial trophoblast. Syncytial trophoblast lost their cell boundaries. They become cytoplasm with a sheet of cytoplasm with a nucleus. Lacunae appears, cavities appear called lacunae appear. That lacunae become they contact each other and lies around the trabeculus. That is that part of syncytium is called the trabeculus. Now the cytotrophoblast, which is a single layer of cells, started growing into the trabeculus. Okay, so the trabeculus now has a central core of cytotrophoblast covered by an outer layer of syncytium. Can you remember that? I will show you the picture. It is surrounded by the maternal blood filling the lacunar space. Okay, you should repeatedly you should read, then only you can. But you people are very familiar with all these things because you are very fresh from the embryology. I know this is a very difficult topic, but you should study this at least to know how this placenta is formed. Fetal circulation is much more important than this formation of the placenta. So, but you should know how this placenta is formed because placenta is a essential part of the fetal life, and these villi are the essential component of the placenta. Okay. So thus the maternal blood filling it is surrounded by the maternal blood in the lacunar space. So the trabeculus is now called the primary villi. That is trabeculus, which is invaded by a layer of cytotrophoblast surrounded by the syncytium, which is surrounded by the maternal blood, is called the lacunar primary villus, and the lacunar space now called the intervillus space. The extraembryonic mesoderm lining. So first the cytotrophoblast grows into the syncytium trabeculae. Now the extraembryonic mesoderm lining the inner side of the trophoblast now invades the center of each primary villus. So you can imagine the primary villus as the cytotrophoblast covered by the trabeculus, then covered by the lacunar space. Okay. Now the extraembryonic mesoderm lining the inner side of the trophoblast now invades the center of each primary villus. Soon thereafter, blood vessels can be seen in the mesoderm forming the core of each villus. With their appearance, the villus is fully formed. That is called the tertiary villus. So primary villi, only the cytotrophoblast enters into the trabeculus. Then comes the extraembryonic mesoderm. Then comes the this blood vessels. That is called the tertiary villus. Okay. Here you can see the core of. There is you can see the primary villus. That is, you can see the trabeculus and the layer of the trophoblast, that is cytotrophoblast entering into the syncytium. Then the you can see the extraembryonic mesoderm entering into the mesoderm. Then the blood vessels. So you can see all three in this. Can you imagine that? You just go through the figure and you will get it. Then the blood vessels of each villus establish connection with the embryo, and fetal blood now circulate through the villi, maternal blood through the intervillus space. Okay. So the center of the villi, each villi is having the blood vessel carrying the fetal blood vessels, and So the center of the each villus is having the fetal blood vessel, and the lacunar space is having the maternal blood. So exchange transfusion occurs through this. So the fetal blood now circulates through the villi, maternal blood through the intervillus space. In the early stages, the cytotrophoblast does not penetrate the decidua, but later it emerges through the sensation. I can't show you the picture because I am not familiar with this thing. Okay, anyway, you just imagine that cytotrophoblast just penetrate the early stages, it won't penetrate, it doesn't penetrate through the decidua, but later it emerges through the sensation of the each villus, and the cells of the cytotrophoblast now spread out to form a layer that completely cut off the sensation from the decidua. That is, cytotrophoblast come to lie at the outer surface of the decidua. Okay, sensation, the cytotrophoblast goes through the sensation, go out, and it just separate the sensation from the decidua. Okay, this layer of cell is called the cytotrophoblastic shell. The cells of this shell multiply rapidly and the placenta increase in size. That's why the placenta increase in size. The villi that are first formed are attached to the fetal side, that is embryonic mesoderm, and to the maternal. So the villi that are first formed are attached to the fetal side to the embryonic mesoderm and to the maternal side to cytotrophoblastic cells. Can you imagine that? Cytotrophoblastic cell that grows through the syncytium and goes and attached to the decidua, and it form a layer outside the syncytium. Now the syncytium doesn't have a contact with the decidua. Cytotrophoblastic shell is comes in contact with the all around it comes in contact with the decidua. That is called the cytotrophoblastic cell. They are thus called the anchoring villi. So the villi that are first formed are attached to the fetal side of the embryonic mesoderm, to the maternal side to the cytotrophoblastic cell. Got it? After the formation of the cytotrophoblastic cell, the cells of this shell multiply rapidly and placenta is increased in size. After that, the villi, how it is attached to the maternal side and the fetal side. The villi that are first formed are attached to the fetal side, to the embryonic mesoderm, and to the maternal side to the cytotrophoblastic cells. You should imagine it. I can't show you this picture. They are thus called the anchoring villi. Each anchoring villi consists of a stem. So that single unit of villi, that is the base part of that villi, that is whole part of the villi is called the anchoring villi. And each anchoring villi consists of a stem, that is the truncus corae, and each this trunci corae is then divided into branches that forms a rami corae. Then each again divided into finer branches like rami corae, and rami is attached to the cytotrophoblastic cell. That is, from the base it is truncus corae, rami corae, then rami corae that is attached to the cytotrophoblastic cells from the fetal side to the maternal side. Each anchoring villi gives off numerous branches which grow into the intervillus space as free villi. So villi, these are the essential unit of the placenta, villi. New villi are sprout from the chorionic side of the intervillus space, and the placenta increase in size. So can you see this picture? You can see the truncus corae, rami corae, and which is attached to the maternal side and the fetal side. You should see this picture and study, then will you get it. Then ultimately almost the whole intervillus space become filled with the villi. As a result, surface area available for the exchange transfusion becomes enormous. So the maternal blood is available at the lacunar space, and the fetal blood at the intervillus in the villi, in the internal part of the villi. Then placenta now becomes, as a result, surface area available for external transfusion becomes enormous. This thing becomes enormous. The placenta now becomes subdivided into number of lobes by a septate that grows into the interval space from a maternal from the maternal side. Septates are formed from the maternal side, and these form each cotyledon. Each such placenta on the maternal side is called this whole placenta is divided into small cotyledons by a septate divider that is from the maternal lesion. Each segment by the septate that is derived that is formed from the side of the maternal side, from the maternal wall. Then from the maternal side of the placenta is viewed, the base of the septate are seen as grooves, while the cotyledons are appear as convex areas. When you see the placenta, you can you will understand all these things. Now you can only imagine what is happening. What will happen? What is the picture? You can see the picture of the placenta from your text. Then you can understand all these things. But how it is formed, you should study. And the cotyledons are appear as convex areas bounded by the grooves. These lobes generally, how many cotyledons? There is around 15 to 20 cotyledons are there. And each such lobe containing number of anchoring villi and their branches. Okay. So anchoring villi has got a stem, truncus chore, rami chore, ramulus chore that is attached to the maternal side, and the stem is attached to the fetal side. Then the placenta now forms a compact mass which is a disc shaped. Okay. Then a full-term placenta has a diameter of 6 to 8 inches and weight 500 grams. Average. If suppose the baby is large, fetus is large, then the placenta also become large. That as in case of diabetes, that is macrosomic babies. That is large, more than 4 kg babies. After the average, it is around 500 grams. Then after the birth of the baby, placenta is shed off, and there are so many methods of placental shed. And there is the clinical aspect is sometimes the placenta become adherent, they don't come out after the delivery of the placenta, manual removal of the placenta. Sometimes it is morbidly adherent and you have to do hysterectomy for that patient. Mainly in a case of previous cesarean section. So placenta is very important in our point. So the attachment is very important. Where is it attached? That is upper part of the uterus, lower part of the uterus, lower part of the uterus. If it attached to the lower part of the uterus, that is placenta previa. Normally it is in the upper segment, it is attached. Lower part, if it is attached, there will be postpartum hemorrhage, that is bleeding after the delivery of the baby. So attachment of the placenta is very important. Delivery of the placenta is important. Fetal circulation is important. So knowing about the placenta is very important. In our department, that is obstetrics. 9. Maternal surface is rough and is divided into cotyledons. The fetal surface is smooth, lined by amnion, by divided into cotyledons. Here is the umbilical. Here where the umbilical cord is attached. Okay, this is the part of our class that is dealing with the development of the placenta. This is very difficult. You have to read it 2 or 3 times, then you will get for these diagrams and you will get it. Now we will come to the clinical part of it. That is the trophoblastic disease. I will give you a rough idea or general idea about this disease, and you will study it in your final year or 4th year classes. We will study it in detail. So these are the gestational trophoblastic disease means a group of disease, that is heterogeneous group of interrelated lesions that is arise from the placental trophoblasts. That is it is divided into 2, that is pre-malignant lesion and the malignant lesion. It is very important because if you diagnose it earlier, then you can treat it, and you should treat it and you should clearly follow that patient. Otherwise, that can be turned into malignant disease and the life of the patient become a problem. because first this is so the pre-malignant lesions are hydatidiform mole and hydatidiform mole or complete mole and the partial mole. Have you heard about all these things? Anybody? Anybody? Trophoblastic disease, have you heard about that?
No, ma'am.
No. So it is very difficult for you. Anyway, you just study that there are two the disease arising from the trophoblast. Trophoblast, we have discussed it. What is trophoblast? How placenta is formed? From the trophoblast, these diseases are arising. Okay, that's why it comes here along with the development of the placenta. This trophoblastic disease. So the trophoblastic disease, the benign disease or the pre-malignant disease are complete mole and partial mole. These are important because this is an abnormal pregnancy. Abnormal pregnancy. In this era of ultrasound, you can diagnose it as early as possible in 8 weeks. 8 weeks or first trimester, you can diagnose it. Previously, we don't have this much ultrasound and we don't have to, we can't diagnose this because after some time, the placenta, the uterus is growing, but there won't be any fetus inside that. This thing, in this hydatidiform form, there is hydropic degeneration of the trophoblast and avascular necrosis and trophoblasts are enormously growing. That is the problem. Have you heard of some of you may heard about the Mundiricula gerbum? Have you heard about that? So anyway, there are pre-malignant and malignant lesions. Pre-malignant lesions are the hydatidiform mole and the complete mole and partial mole. And the malignant lesions are invasive mole, choriocarcinoma, and the placental site trophoblastic lesion. So you can diagnose this hydatidiform mole from your as early as in the first trimester. So what are the clinical features? The clinical features are the patient may present with a severe vomiting, that is hyperemesis, admitted with the hyperemesis. Whenever a patient admitted with the severe vomiting, when a patient came to the casualty with the severe vomiting, always think about the two conditions. That is, one is multiple pregnancy and one is the vesicular mole, because wherever there is an increased amount of HCG, that is here the tumor marker is HCG. There is increased amount of the HCG that will cause the vomiting, severe vomiting. So you have to do an ultrasound and rule out these two conditions, hydatidiform mole and multiple pregnancy. So in the hydatidiform mole, you can diagnose it as a snowstorm appearance and there won't be any fetus. But in partial mole, there will be some amount of the this. You can see the snowstorm appearance and vesicles you can see, but sometimes there will be one amniotic cavity, or sometimes you can see the fetus in that, but that won't grow. That is the problem. As soon as you diagnose this thing, you have to terminate that pregnancy. Whenever you diagnose complete mole, you terminate that pregnancy. So what are the clinical features? Patient may present with the after amenorrhea, pregnancy test may be positive, but the patient may present you with a bleeding PV, history of passage of vesicles, history of hyperemesis, all this. Whenever you see a patient with a hyperemesis, always do an ultrasound and rule out hydatidiform. So after diagnosing the hydatidiform mole, as soon as you diagnose, you have to terminate that pregnancy and you have to take a pre-evacuation HCG. After evacuation, you have to follow the patient with HCG. And if there is a regression of the beta HCG, there is no problem. That pregnancy will go smooth and that termination will go smooth. There is no possibility of post-molar trophoblastic disease. That is, there is 20% chance of grow into a malignant disease. That is post-molar trophoblastic disease. That is choriocarcinoma, invasive mole, and placental site trophoblastic. That is the importance of follow-up this patient. So as a case of a missed abortion, you can just leave that patient alone. You have to follow the patient weekly with the beta HCG and see that there is the beta HCG is regressing. After 8 weeks, that should come to normal. That is the normal. Then if it is comes to normal, then after 6 cycles, you can 6 normal cycles, that lady can become pregnant, and you have to do early ultrasound and rule out the vesicular mole in the next pregnancy. So as soon as you diagnose the hydatidiform mole, you have to terminate that pregnancy. Then next is partial mole. That is between these two, you can't see any fetal tissue in the hydatidiform mole or complete mole. In the partial mole, you can see the fetal tissue, you can see the blood vessels, and the chances of, previously we thought that this partial mole is benign, but nowadays we know that 5% of this partial mole also can turn into malignant disease. So in case of complete mole, it is 20%. That is that can be turned into malignant disease. That is choriocarcinoma. But if you are following this patient, that is follow-up is very needed for this, very, very important in this patient. As soon as you diagnose complete mole or partial mole, you terminate that pregnancy and you follow up that patient with the beta HCG. So the tumor marker for the this trophoblastic disease is beta HCG. So you follow up the patient up to 8 weeks. If it is normal, you can leave, or you can wait for 6 normal cycles, then that patient can become pregnant next time. But if you see a rise in the beta HCG on your follow-up period, or the beta HCG is not coming to normal, there is a plateauing, or there is an increase, then, and it is not coming to normal, or slow regression, all these are the warning signs that you should follow that patient quickly, because you have to take the chest X-ray, and you first thing you should do a check curettage after the termination is usually done by the dilatation and curettage. That is as any case of abortion you can do. In the first trimester you can do. All this you will study later, but I am just telling what will happen to the hydatidiform mole, because this clinical part is important for us. That embryology part is just to know what is trophoblast and how it is formed, how placenta is formed. But the clinical part is more important in your clinical classes. That's why I am talking all these things, because you will study all these things later in detail. But just know that there are pre-malignant and malignant lesions. Pre-malignant is complete mole and partial mole. Malignant is invasive mole, choriocarcinoma, and placental-site trophoblastic tumor. And as soon as you diagnose the pre-malignant lesion, you terminate that pregnancy and you follow the pregnancy with your beta. And if it comes to normal, okay. But if it is going up and slow regression and plateauing, then there is a chance for turning it into a malignant lesion. So you should treat it. If it is, if the values are increasing, first you should see whether your evacuation or termination of pregnancy is complete or not. See whether there is any trophoblastis left behind inside the uterine cavity. If it then also the beta HCG become high. So if there is a retained products of consumption, you have to remove it. So you have to do a check curate. You can do. Previously we used to do a check curate at 1 week after the first curate, but nowadays we are not doing that, because we can see the products that if it is inside the uterine cavity. Okay, so check curate and give them. If there is nothing inside the uterine cavity, you should think about the postmolar trophoblastic disease or the malignant disease. That is the either invasive mole, choriocarcinoma, or placental trophoblastic tumor. So these are the gestational trophoblastic diseases in nutshell. Okay, so you have to terminate that pregnancy. One more thing, that how will you treat this if you are diagnosing a postmolar trophoblastic disease? You can cure it completely. Okay, because it is very much this malignant disease will respond to the chemotherapy. That is single agent chemotherapy. That is methotrexate. Methotrexate very much This is very sensitive. It is very much responding to the treatment with the methotrexate. You can follow again. You can follow the effect of the treatment using the beta HCG, and when it comes to normal, you can again you can give the methotrexate 2 or 3 more cycles. Then after that, after the completion of the chemotherapy, you should advise the patient. The patient may ask, because it's a long period now. Suppose it is a first pregnancy, the in-laws and both the in-laws and the patient's guardian also, they are all very much concerned about these things. No? If it is an abortion, after evacuation, they can become pregnant within 1 or 3 months. 3 months to 6 months, they can become pregnant without any problem. But in this case, you have to follow them, follow that pregnancy after evacuation, and the beta HCG should come to normal. And if it is not coming to normal, and this thing, if you diagnose a postmolar trophoblastic disease, then you have to treat with either methotrexate. Usually that will respond. And if the beta HCG comes to normal, you have to wait for you have to repeat the chemotherapy for 1 or 2 cycles. Then you have to restrict the pregnancy, or pregnancy should be postponed after nearly after 1 year. That means 1 to 2 years after the marriage, they will become pregnant. They will get, and they should be very. That is the problem. Why first time if they are become pregnant, and that become that time to be a hereditary form, that's a problem. So this is the importance of the trophoblastic disease. You have to diagnose it earlier and treat it, then follow it, and prevent become a malignant disease. And sometimes this methotrexate is not enough, because this is not responding to the method. You have to go for multiple agent chemotherapy, Imaco regime, all these things. Okay. So you should go and study this development of the placenta. Other thing you can study from your clinics. You will see the case, how this complete or hereditary form is diagnosed, how choriocarcinoma become important, why this methotrexate is important, how this chemotherapy is given to these patients. All this you can, I don't know when it happens, but that you can see all these things from in your clinics, in your OP, in your labor room. You can see all these things, but you can see the placenta also. Placenta, and because I can't show you these pictures, because this laptop is not mine, so I don't know how to operate this. And it is not here also. So you just see the placenta and how this cotyledons looks like, and what is a villi. You should study the fetal circulation mainly. That is different thing, not in connection with it, but how this fetal circulation occurs and the external transmission occurs from the contact with the fetal blood and the maternal blood, how it occurs, that you should study from this embryology. Then how this just trophoblastic disease happens, that in general, these are the diseases, and so many other diseases are there. The hypertension, diabetes, all these are all these are come trophoblast from the disease. Some part is there for this trophoblast. For recurrent abortion, trophoblast come there. There's hypertension, trophoblast is there. Then diabetes. In pregnancy, mainly gestational trophoblastic refers to these diseases, pre-malignant and malignant disease. Okay. So today you go and study the development of the placenta and the trophoblastic disease. What are those diseases? That is pre-malignant and malignant disease. What is the importance of this? That much is needed for you now. Okay. Shall we stop? Okay.
Okay, ma'am.
I know that it's very difficult to understand from, and it's for me also, it's difficult to take a class without seeing all of you. And anyway, thank you very much for your patient hearing, and go and study this. Okay.
Okay, ma'am.
Okay. How can I get your attendance?
മാം ചാറ്റ് ബോക്സിൽ ഇട്ടിട്ടുണ്ട് റോൾ നമ്പറും പേരും.
എല്ലാവരുടെയും
മാം ഇതിൽ സൂമിലുള്ള എല്ലാവരും ഉണ്ട്, യൂട്യൂബിന്റെ കമന്റ് ബോക്സിലുണ്ട്.
ഈ ചാറ്റ് from here, I think Shadit will get it for me.
ഷാജിത് സർ അത്
എടുത്തു തരും അല്ലേ? Okay. Anyway, thank you.
താങ്ക് യു.
Thank you, ma'am.
Okay.
Thank you, ma'am.
Thank you.